So I think if we just do the preamble first, I'm sure you've been on loads of these calls, but we will be recording. So if you don't want to have your face recorded, please, this is your time to go, or put your camera off. If you could just put yourselves on mute, that'd be really helpful, just so we can have real clarity for when our speakers are talking. We will be sharing the slides. I think I heard in the background that our presenters are quite happy for the slides to be shared a bit later. And of course, they will be part of the recording. So are we ready to go, Steve, do you think?
I think so, yeah. Let's make a start.
Okay. So good morning, everybody. I'd love to say it's lovely to see all your faces, but we can't in this way because we've got the agenda up. But thank you so much for dialing in. We've got about just under 50 people on the call, so that is absolutely fantastic. My name is Sian Harris, and I'm new to this call. I'm new to this programme of work. So I sit within the People's and Communities Subdirectorate, as we're called now, as part of the National Nursing Team of NHS England. If somebody just could put themselves on mute, that would be great. And we, as you probably realise, are transitioning into some new roles now. So we are going to be the new Experience and Partnerships team. And I'm one of the Experience of Care leads of 4 that sit in, well, it's actually, sorry, 6 now, that sits within this team. And I'm going to be picking up the policy lead for unpaid carers. So I think that's probably about enough now. When we come to the next call in the new year, we'll be able to give you a bit more detail about our work at the NHS England, at the national team, but at the moment it's all very much moving chairs. So we've got a really fantastic agenda for this hour's meeting, and we'll make sure that we finish by 11 o'clock. So I think the best thing is if we go straight into the agenda, please, Steve. If you could just, have we got another slide?
Yeah, we've got, I'm just passing it on to Morag now to share a screen.
Okay, so I am going to hand over to our first speaker. I am not going to get pronunciations wrong on my first call. So Morag, if it's all right with you, if you would mind introducing yourself and your area of work and what you're going to talk about, I would be incredibly grateful. And it's over to you. My understanding is that if you could put any questions you have in the chat box, and then we'll have a Q&A session at the end. Is that correct?
That's fine with me. If that works for everybody.
I think so.
Great, I've noted through. Could somebody just confirm they can see the slides, because I can now only see Sian.
Yeah, we can see the slides. That's great. Thank you, Morag. So over to you.
Lovely. Thank you so much for that kind introduction. So I'm here to tell you about the Carer Support Nurse pilot that's been running in Great Yarmouth over the last year period. So before I move on, I should just acknowledge that this is not just my work, it's the work of the whole team from UEA, London South Bank Uni and University of Hertfordshire, as well as PPI representation. So I don't need to tell this group, provide my usual introductory slides on who carers are, what they do, what they prevent, how complex their lives can be, or the impact of their caring role. So I'm going to focus just on the rationale for the carer support nurse role that we introduced. So we know that carers have health-related support needs. They have health-related education needs, and they need specialist knowledge and skills, but often lack training. We also know that the caring role negatively impacts carers' physical and psychological health and even their mortality. There are lots of reasons for this that you all know, but it's largely down to them putting their own health second, prioritising the patient, ambivalence towards their own health, and just that reality of the caring role and their lack of time. And this threatens their own health and threatens their caring role. So the threats to carer sustainability are that the carer role is characterised by this uncertainty and unpredictability. Carers are rarely acknowledged and largely unsupported by clinicians. Support from social care and the voluntary sector, it tends to be stronger, and this threatens carer health and patient support, which can lead to patient and carer crises. We know that by supporting the carer, we actually support two people, both the carer and the patient. And there's a large health policy rhetoric around this, saying that carers should be supported, but these documents very rarely give guidance on how that should be done. So our solution to this was to trial a carer support nurse role. So this role targets nursing skills within existing structures that cross systems. And there are two key evidence-based prerequisites for this role. First, that it's dedicated to carers, and second, that it is a nursing role. So it's dedicated to carers due to carers' known reluctance to bother healthcare professionals during what they see as patients' time, and nurses' challenge in supporting carers within their patient-led roles. And it's a nurse due to carers' known unmet health-related support needs, both their own mental and physical health needs and their needs in their caring role and the educational support that that requires. And this differentiates the carer support nurse role from other roles, such as social prescribers or care coordinators. So it's filling a unique gap identified by stakeholders that requires nursing skills complementing existing services. So the role was a one-year pilot, ran from October to October, funded by Norfolk and Waveney ICB, hosted by East Coast Community Healthcare, and it was based in Great Yarmouth and Northern Villages, so right on the coast in something called a primary care home team, which is a multidisciplinary team supporting clusters of GP practices. Norfolk and Waveney ICS strategy has a dedicated carer section, noting that the needs are becoming increasingly complex, and so their service improvements need to be more coordinated and effective for the service user and their carer. And their web page also acknowledges the vital role of carers and how national and local data consistently show the negative impacts of carer health. And we know that in Norfolk and Waveney, ICS carers have higher than national average of long-term conditions, arthritis, back and joint problems, and mental health conditions. And they've cited this role as one of the ways that they're meeting their pledge to support carers. So the pilot was a collaboration between East Coast Community Healthcare and University of East Anglia. So it saw healthcare and academia working together to develop this evidence-based role in delivering evidence-based nursing practice. When developing the role, we did extensive stakeholder consultation. We worked with over 70 stakeholders regionally across health, social care and the voluntary sector, national leaders in carer support from NHS England, QNI, Adult Social Care and Carers UK, and over 100 carers and patients. And there was universal enthusiasm for the role when we were in the process of developing it. Locally, carers in Great Yarmouth confirmed the national evidence around carer needs in relation to their health and well-being. They told us that they felt their needs were not being met, but instead felt assumptions were made about how they were coping. They could feel abandoned or passed around by services and underappreciated and overlooked. They welcomed the idea of the role. They felt it could create a space for their needs to be discussed, provide opportunities to talk to a professional who understood how difficult it could be for them to open up about their own needs and would fill gaps in existing care support. So the role was developed around these 5 evidence-based principles. First, that it should be community-based. Second, that it should be cross-sector working, so receiving and making referrals across health, social, and voluntary sector. Third, that it should deliver person-centred care to carers with complex needs, complementing social care, assessment and practice. It should attend to marginalised communities, be educational, both to carers and other healthcare professionals by raising their awareness of carers and modelling better practice. And the carer support nurse pilot role was fulfilled by Karen Murphy, who was happy to be named. She came with 5 years acute care experience in orthopaedic trauma and specialist pathology, and over 4 years experience as a community nurse. So she took on this role as a 1-year secondment. And the referral criteria we developed for the role were for carers living within the area who have complex support needs relating to or impacting on their own health or well-being, or their skills or conflicts to care, or unresolved health-related support needs that could not be met by their usual healthcare team. And the key thing here is that that complexity lies with or relates to the carer rather than the patient. In terms of evaluating this pilot role, well, it was led by us at UEA, funded by formerly Health Education England, East of England, now NHS England, supported by the NHR Applied Research Collaboration for the East of England and UEA's Health and Social Care Partners, who are working with collaborators at London South Bank, University of Hertfordshire, and our Carer Public Involvement Group. We also have an extensive advisory group which has some key national leaders in care support, as you can see there, as well as experts in relation to both the methods and the delivery of the role. And in addition to this, we had our carer advisory group. So this was a pilot project, and this is just a reminder that this was a pilot. So we were trying to answer, can we do it? Might it work? And also, how can we find out if it works or not, or how it works or not, rather than simply, does it work? So this project was hopefully to lead the way for more work that can follow on from it. And it was a three-stage pilot. So stage one explored how the role could work. And during this period, we identified local, regional and national carer resources for the nurse to use. We also ran workshops and interviews with carers, health, social care and voluntary sector professionals and commissioners. The second stage was to actually evaluate the role once it was up and running. So she came into post in October 2022, and there was a period of developing policy, conducting induction before she started seeing carers later in November, early December. And what we did in this stage two was to look at the value and impact of the role, looked at what she did, what the views were of carers, patients, and those cross-sector professionals who were working with them. And then the final stage was stage three, developing recommendations. So thinking about when and how to introduce the role elsewhere, what we'd learned about carer support, and also what we'd learned from a research point of view about how to evaluate these sorts of roles. So I'm going to just give you a very brief overview of the key findings. The final report is available, and I'll give you a QR code and you can access that at the end. So I'm going to run through very quickly the types of carers the nurse saw, what she did, what the impact of the role was on carers, key stakeholders' views on the role as delivered, possible mechanisms of action, and resulting recommendations. So who did she see? Well, she had 124 referrals over the 9-month period that we actively collected data. 73% were female, the age range was 20 to 95, average age of 66. She had no referrals for young carers, although she did see some young carers through other routes. In terms of the referral source for carers, well, most of the referrals came through the ex-primary care home team. There were some self-referrals, which is really good to see, and there were referrals from social care and the voluntary sector, but they were lower than we'd anticipated. In terms of the primary conditions for the caregiver person, so just with the caveat that this is quite crude data, because obviously most of these patients that carers were supporting had more than one condition, but a large majority had dementia or Alzheimer's, and some of this relates to one of the sources of referral, which was a newly created memory and planning nurse role within East Coast Community Care. In terms of the support needs that these carers had, so one of the interventions that the nurse delivered was the carer support needs assessment tool intervention. And part of this intervention, it asked carers to complete a booklet identifying their areas of support need. So the items you can see here relate to what is in that booklet. And what's encouraging about what carers have identified in areas of support need is that the first two on this list relate directly to the referral criteria for the role. So looking after your own health, physical problems, and dealing with your feelings and worries. So this was reassuring in that the right types of carers seem to be being referred through. So what did the nurse do? Well, Karen summarised for us what she felt she did, and this is one of many sources of data we had on what she was delivering. So it was about carer role acknowledgement and listening. It's about providing person-centred assessment of solutions using SESNAT-I, so that intervention I just mentioned on the last slide. And what SESNAT-I does is it opens up conversations about what's important to the carer and their unmet support needs, and then enables solutions by working together to address those physical, social, and emotional needs identified. It was also about providing screening on carer health and coaching, upskilling the carers, assessing risk of care breakdown, providing crisis management, and identifying and managing safeguarding concerns. But as well as directly supporting carers, she also worked to develop links with other organisations, promoting the roles with presentations and being shadowed, providing advice to other professionals, attending multi-case conferences, training, and also completing admin tasks. But a key feature of this role was the extensive interprofessional intersector working she did across health, social care, the voluntary sector, and emergency services. And she was described by some as a super connector or a knowledge broker. In terms of the activity she did, this rather scary pie chart was part of the activity analysis that was led by Alice Leary from London South Bank. And what this shows is the proportion of activity taken by the nurse and how it was distributed across different types of work and across the nursing process through assessment, planning, intervention, and evaluation. And this shows the benefits of having an experienced registered nurse in this role. So it wasn't just about having a chat and signposting carers. It was a full assessment and then a plan and an intervention. And within the main report, you'll see that there are other analyses showing the frequency of these activities, and in particular the response to the psychological needs of the carers, as well as the physical and social needs of the carers, were all undertaken by the carer support nurse. In terms of where this activity happened, well, we're pleased to see that most of it happened in carers' homes, and we had direct feedback from carers that they found this in particular something that they really valued. So what was the impact on carers? Well, in terms of the carers we interviewed, the feedback was overwhelmingly positive. What was really interesting was that referral in itself was considered an intervention. So just knowing they had been referred had a positive impact on them before they even had the first contact with the nurse. They really valued having these opening up conversations, so being able to share their experiences of being a carer and discussing difficult issues and feelings. And this sometimes led to them then be able to share them with their families. They valued the practical support that was put in place. They welcomed the opportunity to re-engage if they needed to, but some of them said it would have been really great to have a more proactive approach if there was a larger team in place. Carers really liked the fact that Karen was an experienced, mature nurse. This came up repeatedly in the carer interview. This is just one quote from a carer who said she seemed to be a very good choice because she's obviously very experienced and knows she seemed to be able to cover everything that's required. And this triangulates back with that activity pie chart I showed you, which evidenced the nursing process, the benefits from experienced registered nurse being involved. So what she was doing was creating psychological safety for carers to express their distress. She was then able to assess and respond to that distress with the carer using actions such as referrals, which again are seen in the activity analysis, are all based on assessment. And one of our carer PPI group asked us to ask Karen at the end of the pilot which skills she felt had been priceless during this period, which I thought was a fantastic question. And she sort of endorsed what I've just shown you on the last slide, because she said, I think you're definitely looking at senior. You need the experience. People value that experience. I don't think we would have had loads of people opening up as they've done with me with somebody who's fresh out of nursing school. You do need that life experience, that maturity. You need to have that. You need to be relatable. So in terms of quantitative data, there's a huge caveat here because we evaluated one nurse for 1 year, and we had data collection over just 9 months on a very small sample size. However, in terms of the quantitative findings, we found a small but non-statistically significant improvement in care quality of life, a signal of improvement in mental well-being, and improvement in carer's sense of preparedness to take care of the cared for person's emotional needs in particular, which probably relates to the fact so many of the patients had a dementia diagnosis. But I would say that any quality of life or other improvement or maintenance is encouraging given the vulnerability and complex needs of growing carers and caring well trajectory. So I'm going to give you probably just one example of a carer. So this was Joyce. She was carer to her husband for 4 years. He was diabetic with a broken ankle, poor mobility, falls, he was forgetful with a recent dementia diagnosis. Her role, which you can predict, covered medication, personal care, managing his incontinence, admin and finance support, appointments, driving, using a daily monitoring call button to monitor him, and managing frequent UTIs. The report she had before Karen went in, there was very little support. Her family were very busy. She was very tearful, not hoping her sleep was disturbed. She was referred to the care support notes by a psychiatrist, and she described what Karen did. So she provided a home visit, and the carer really liked this. There were also 2 follow-up phone calls, and then an invitation to ring Karen again if needed. Karen did a depression test, referred the carer to a GP, who's then administrating meds and counselling. What the carer valued was that she would listen to, the fact that Karen was very patient and she was able to talk to her, the fact that Karen understood what was going on, particularly the anguish she was experiencing, which she then felt able to share with her staff. She liked the flexibility of the service. She valued the resources that were shared for her and recognised that Karen was mindful not to overwhelm her with resources. She spoke particularly about the fact that Karen was experienced and mature, which felt she meant that she could talk to her and share things which she couldn't with others. And just the fact it was helpful to know that Karen was there was valuable. So Joyce said she was very patient, just worked through her things that she needed to do and listened and chatted. And I think she understood where I was coming from and what the situation was. You can say things to someone who's not emotionally attached, you say. You can't say to your family because you hold back a lot of stuff from them because you don't want to upset them and you don't want to worry them. It's an essential role and it's a brilliant idea. I hope that it's rolled out. I'm going to skip the other example in the interest of time and share with you what the key stakeholders felt about the role as it was delivered. So we asked them about their initial perceived need for the role before it began, and all but 2 of these cross-sector stakeholders knew that the role was needed, and the 2 who were uncertain to start with said that they found very quickly, as they learned what Karen was doing, that the role really wasn't needed and it was doing something that they were not themselves delivering, that they thought they were, which was really interesting. And both of those were nurses. In terms of the value of the role, the stakeholders gave again overwhelmingly positive feedback. They valued the added value of this new resource. So it didn't create more work for them. It was a new resource that they could refer to. And there was frank dismay at the fact that the pilot ended and that the role was not been efficient so far. We asked them about those 5 evidence-based principles I told you about at the beginning and whether they were delivered and whether they remained relevant and important. And they said yes to all of these, but they noted that working with marginalised communities takes more than a year. And although Karen started on that, there was more work that could be done, but it would take time to build that trust. We asked them about operational refinements, so things like whether the referral process works and the criteria worked, and they said it did, but they recommended further promotional work if the role was rolled out, but with the caveat that actually that would need to be where the team was in place because actually Karen is up the waiting list. They also talked about the issue of records access, the fact that Karen had a carer record but couldn't access patient records. Those with patient records couldn't access the carer record that Karen created. And then a couple of stakeholders who were in a triage role said that they would have liked to receive feedback about the case, but actually reflected that they rarely did that in terms of any of the referrals they made because they were in this triage role. They said it fitted very well with existing services. Nobody had to change what they did other than a social prescriber. And what happened here was that for some reason, the GPs couldn't directly refer to the carer support nurse. There was some infrastructure problem. So they had to pass that referral to the social prescriber, who then made the referral. And this social prescriber said this did add to her workload, but actually she could see the benefits for those she was supporting, so she was happy to do that. And what they also said was that, as well as it being a good fit, Karen actually absorbed some of the activity that they themselves would normally be doing, and also absorbed the additional activity that she was creating. So rather than just simply moving it on to someone else. So the fit was good. Here's a healthcare professional who said, I recently tried to refer somebody through to Karen, and I was told no, that the service is no longer available, and I was gutted because there's very little else out there for carers. There are voluntary organisations, I get that, but this was specific for the carers and to look at the carers' needs. You know what I mean? To look at their physical and mental health needs, and to offer education and support, and best to support their life on their own. So I found that was a really effective job or role, and I'm quite lost without it, to tell you the truth. One other quote from a stakeholder, this is a social care. You said you don't really realise what you've had until you've lost it. I've literally got a case coming half an hour ago that Karen came straight into my mind to give support to, which is someone who's newly in the position to give palliative care to their father. And what's quite sad is they're already looking forward to the time in which their father dies, so that it doesn't have this impact on them. You get this. But without a shadow of a doubt, once Karen came, I thought, this is brilliant. I was really surprised that Karen was the only one in the whole country. And yes, there is a need, 100%, somebody who's skilled to recognise certain responses to care before it's too late. So we noted earlier that supporting the carer actually supports two people, the carer and the patient. But what we were finding was supporting the carer through the carer support nurse, either directly or indirectly, actually supports three people, the carer, the patient, and the referrer. There was also unsolicited feedback from some sources, so from East Norfolk Medical Practice. They said we've been very fortunate to work with Karen, and so far the difference she's making to our patients is incredible. In December last year, she's seen 45 carers via various referral routes, which is the highest number of engagements with care support over all of our practice areas. This is very positive that we're going in the right direction to ensure that carers are supported. Karen says we've only just scratched the surface. So I mentioned a couple of times we had a care advisory group, and we shared some of the anonymised care interviews with them and asked for their reflections. And they were struck by how Karen was able to sort things for carers, the efficiency, the connections she made, the super connected role again, and her ability to help carers prepare and have headspace. They also commented on what she was able to achieve in one visit. They again felt her experience and maturity was a key factor in delivering the role. They also recognised that if there was a bigger service, if it was a team rather than one nurse, that the role would be more proactive. But very interestingly, they noted the need for support for the care support nurse herself, given the emotional burden which she was taking on through these consultations. So I now want to just move on to the possible mechanisms of action. And to develop these, we obviously looked at the whole breadth of data we collected across this pilot. We worked with our care and PPI group and our expert advisory group that I showed you on the slide earlier. And the things that we've identified through that analysis of the data is that the care support nurse, was potentially acting as a direct care intervention for carers with complex needs. It was a means to raise healthcare professionals' awareness of carers and their support needs and the importance of technology for addressing those needs. It was a means to raise carers' awareness of their own support needs and the importance of attending to their own personal well-being, both for themselves and to sustain the caring role. It was a means to prioritise the identification and addressing of carers' needs related to their health and well-being, a means to facilitate carer access to healthcare for their health and well-being needs. It was a conduit for implementing that intervention I mentioned earlier, the care support needs assessment tool intervention. It was a provider of psychological safety. It was an absorber or container for some of the challenges and difficulties of the caring role. It was a super connector and a navigator for carers, but also for prospective professionals, and the role as a system designer for it. And what we can do with this is develop a logic model for the role, program theory that we can potentially test out in future programs if we can encourage other people to introduce this role that we can then evaluate elsewhere. So we developed 21 key recommendations for the role as a result of this pilot. 6 pivotal recommendations, 5 recommendations relating to establishing a significant role in practice, 5 recommendations relating to organisational support for the role, 2 related to enablement of the role, and 3 recommendations for future directions. So the pivotal recommendations relate to the fact that the role is a mechanism for delivery of NHS pledges to support carers. The second recommendation is that the role should continue to prevent that loss of opportunity, to move to a sustainable role, to prevent loss of developed skills and establish networks. The third one relates to the value of a team model, which could be led by a band 7 nurse, which by band 6 nurses. The fourth one relates to the 2 evidence-based prerequisites for the role that I explained earlier, and that these should remain. It should be dedicated to carers and it should be a registered nurse. This is about the fact that an experienced registered nurse is recommended for the role because of the way that the work is distributed across different types of nursing work and the nursing process, and the importance of the person post-holder being relatable to the target population. The 5 evidence-based design principles should remain, including the care support and secondary intervention as a role. In terms of recommendations related to establishing and delivering the role, well, senior management team and high-level support is required, and this should include dedicated monitoring and reporting mechanisms that evaluate the role in relation to those 5 evidence-based design principles. It's important that time is given to initially build and then maintain and grow networks that are required for the role, given the super connector role she had, and that needs to be acknowledged and handled in the service model. Formal clinical supervision should be provided for the role to ensure that the emotional demands of the role are supported, and it's likely that the proposed team model of recommendations really will enable that. It's important that the first in-person contact with the nurse should happen in the location that most relevant to the assessment of the carer's needs and where the carer feels most comfortable, and that's most likely to be the carer's home, but not exclusively. And the care resources identified for or through the role should be close to healthcare colleagues or shared with other sector colleagues as well. So in terms of organisational support recommendations, the role would benefit from admin support and dedicated contact groups. There needs to be a care e-record system that meets the needs of the nurses required. And where possible, the nurse should have access to the care for person's notes. Other healthcare staff should have access to the carer's notes as created by the care support. And ideally, it's great to have data sharing agreements in place with relevant organisations, as that's what will work very well in this pilot. In terms of enabling the role, the job description would benefit from sort of structuring and presentation refinement. The role should be proposed to carers and cross-sector referrers via strategic early team promotional campaign, particularly if the team model is in place and able to support the increase in the role that this is likely to generate. And then finally, the recommendations related to the future directions. The role should seek opportunities to support young carers' health and well-being. This is an area of development, and the says that I intervention about the mentioning is moving into sort of the young carer arena as well. And once that evolution of that intervention, that's something that the role should be put forward. We do recommend that a larger research and implementation study to explore the role of the service in various locations is warranted. And that where establishment of the role is associated with the research study, including the research of 2017, the role setting is beneficial both to the host organisation, the post holder, and the study team. So just to share some celebrations with you, the role was the regional winner in the NHS Parliamentary Awards for 2023 in the nursing and midwifery category. And we were also shortlisted for an RCMI award in innovation. So from over 900 applications, we were one of 75 finalists who were able to go to the ceremony in Liverpool back in November. So just to sum up, this was an evidence-based role that filled a stakeholder identified gap. Stakeholders felt and the evidence suggested that this was the right solution to try in order to fill this gap. And very importantly, this was a role that was co-designed with stakeholders using the evidence base and was also operationalised locally with stakeholders. So the goal of this role was to support carers with complex support needs relating to or impacting on their own health, well-being and their skills and competence to care, or those with unresolved support needs that couldn't be met by the usual healthcare professional team through delivery of those 5 evidence-based design principles. And this pilot has demonstrated that in a pilot role, this particular nurse is able to achieve that. So I just want to finish with this quote from Philip Russell, who's Vice President of Carers UK as Farquhar Advisory Group. She shared that so many carers like myself would have warmly welcomed an informed, friendly and genuinely interested professional like the care support nurse in our own everyday lives. We talk so much about the importance of personalised care. The digital transformation cannot always provide that personal contact or respond appropriately and confidently is sometimes very difficult So, very importantly, the carer support nurse can see the carers in the context of their own homes, share the reality of their daily lives. I just hope that this project stimulates commissioners, providers and partners to understand the value of the carer support nurse and replicate it. So on this final slide, as well as our acknowledgements, which are really important to the pilot participants and supporters, there is a QR code which will take you to the web page, which is listed there where you can access the final report. There is also an executive summary there, and there is a link as well. And let's stop sharing.
Thank you so much for that, Morag. It's clearly a really successful pilot that you've been leading. There's a lot of questions in the chat box, so can I just quickly start off? There's a bit of a theme in as much as, can you outline why the role was clinical? This has been asked by, I think it's Lizzie. Was it about being relatable, maturity, or was there a clinical element to the role responsibilities?
All three. So clinical is crucial. The two prerequisites for this role is that it's dedicated carers and that it's a nurse. And throughout the pilot, there's always been some voices who said to me, does this really need to be a nurse? Is there not somebody else who can fulfill the role? This role is fulfilling a unique gap related to health and well-being. So it requires nursing skills in terms of assessing carer health and responding to those health needs, rather than simply signposting on, although it did include elements of signposting on and referral as well. Both the carers themselves and cross-sector stakeholders really valued the fact that this was a nurse. And when we looked at that activity analysis, when we looked at what she was doing, it was clear that she was delivering the nursing process, and it played out in the interviews we had with carers, it played out in the interviews with folks which we had with stakeholders again for the pilot, that those aspects of the delivery were what was missing previously, and what is now missing again because the role is ended, and that those aspects of support would have to go back to how carers were being supported before, and it was an area of concern for stakeholders that these needs were now going to be unmet again. So I cannot emphasize enough how important it is that this. The added value on top of that of it being an experienced, mature clinician was something we hadn't expected to find. But yeah, the clinical role is in doing something different to other roles out there.
And I suppose Lynette then had earlier on in the chat had said, you know, understanding the current financial climate and the constraint of the reduced nursing workforce. I wonder what else could be considered. And then also here, Kevin's put, could this be an enhanced part of a carer's champions role within PCN? Absolutely take your point around the experience, the clinical aspect, but actually if we are working in this constrained financial environment, was there any learning that you thought that maybe it could, looking at kind of skill mix, it could be something other than a clinician?
So the whole point of this role is it's filling this gap that's there at the moment, and it brings these new skills. If we use resources that are there already, we're not addressing the gap. It hasn't got a unique selling point. But also really importantly, sometimes I just think we undervalue carers in the, why can't they have a nurse? Carers are just patients who happen to be in a caring role, and we wouldn't try and deliver the equivalent of care to patients using a non-clinical role. So why would we do that for carers? It always really puzzles me when we get that response. So I continue to bang the drum that this is a clinical role. I had some really interesting conversations early on with Jane Kenwood, who was at that point the NHSE for carers, who helped us to think through what banding this role should be at. And being a band 7 role was one of her suggestions, and that's proved to be absolutely valuable. There is the potential, if you have a team, to have a band 7 leading the team, band 6 nurses in there, You could then have a skill mix within that team to deliver aspects of the role, but to do a clinical assessment requires a band 7 or a band 6 role to be able to deliver on that, and to do it properly and to meet the gap that we identified. Otherwise, you're just replicating what else is there already. The other thing I would say is that in terms of, we need to think more longer term in terms of savings. So, okay, yes, this role would cost money to put into place, with potential savings down the line for both care and health, and sustaining that caring role, preventing those hospital admissions, which we can't demonstrate in a pilot of 1 year with one nurse, but we would hope to demonstrate in a larger project where we have more nurses enrolled for a longer period. We've certainly got anecdotal evidence from the interviews of admissions being prevented, but we haven't got enough numbers to be able to do a health economic analysis. So we collected pilot data, health economic data, so that would help us if we did manage to do a larger study going down the line. And we've tested the process, but we haven't had straight away.
Great. So just a couple of comments, I think. So Jodie has said, you know, similar to Admiral nurses, this is a nursing clinical role to support carers. Being an AHP by background myself, a comment about actually could it be broader than just nursing, could be an AHP, allied health professional supporting this role. So all, you know, really good comments. Let's kind of move away from this, and I'm going to go open this out to anybody who wants to come on. If you want to put your raise your hand to ask a question, but just whilst you're thinking about that, did you explore other hospital and how hospitals and providers about how they supported carers at all when you started this? This is from Hayley.
Yeah, so I mentioned earlier we did over 70 cross-sector stakeholder consultations before we even started, and it was so valuable to have done that because we were able to be confident that this was addressing a gap, and that was really important. We didn't just want to repeat what other people were doing. So we were able to map what was going on locally as well as somewhat nationally. And that we were able, in doing that, to develop a resource document for the nurse to use when she came into the role, which she could then add to as she built her networks going forward. And this was a cross-sector resource, which is actually appended to the final report. And so it was important to make sure that we weren't replicating what was there already. We weren't just inventing the wheel. This was meeting the gap that was there. And I think we achieved that.
Oh, thank you. And I think that addresses, there's a couple of people say, you know, what was the gap? And then actually, yeah, making sure there wasn't duplication. So let me go. Yeah. It's Hayley again. So Hayley, over to you.
Hello, sorry, me again.
Hi,
Thank you. Hiya. That's really interesting. Thank you. And it's really good to see that you've identified the clinician part of the gap. So, but I have one concern, if it's all right, if I can raise that. So we, as Suffolk Family Carers, we've had carer support based within hospitals for quite some years now. So we will be looking at the report and trying to work on some of those gaps. So what my concern is how this might impact the voluntary sector that does have carer support based in hospitals, because the role of our carer support, we do have access to records, so we can make put reports on the hospital systems. We have really good relationships with the clinical staff. There was one doctor who set up a carers session alongside her you know, her work. So there was a room especially for carers. And we, as a voluntary sector, we have links to over 400 or 500 other voluntary sector organisations within Suffolk as well. And we have a system where the carer just says their story once, and then we can refer to all the different services. So I suppose my question is, I didn't really want it to impact negatively on the good work that the you know, charity sector is doing. Yeah,
absolutely. And that's why I am really keen, and the team are really keen, that we have a go at introducing this role in different areas, because this model works in this locality. We had these sort of evidence-based principles, but then the operationalisation of the role, that kind of day-to-day working, was developed with local stakeholders. So we knew what was there already and were able to make sure that it didn't tread on any toes. And we had no feedback saying that it did tread on any toes.
that's good.
It was it was meeting, filling a gap. So if this was to happen elsewhere, doing that stakeholder work initially is really important to make sure that it's doing the same job, but it's not treading on anyone's toes, and it is filling a gap, because then it's a waste of time, everybody's time and money, if it's repeating what's there. But also that it works with those resources that are there already. So it has that sort of connection ability, that sort of knowledge broker skill. So it knows about services like yourselves, and it can make referrals to you as well as receive referrals from you. This was a community-based role. It wasn't based in a hospital discharge team, but we had discussions about whether that would be an appropriate environment. But yeah, the key thing is to know what's there on the ground already, isn't it, and make sure that it fits. But yeah.
Thank you. I think that's really good, because it does raise the profile of carers, doesn't it, as well? So
it absolutely does. And we had the interviews with healthcare professionals who worked alongside her in particular said it really raised their awareness. They thought they were giving carer support, but when they actually saw what Karen did and the problems she unpicked and how she was able to address them and the impact it had on the carers that they referred, they really got it. It was a bit of a light bulb moment, and they said that they will carry that going forward. It's increased their awareness, although they still don't have the time and capacity to support their needs. They are more aware, at least acknowledge the care better. So that was really good.
Okay, thank you. Just one last thing. So in Suffolk, we ensure our workers has health coaching training alongside the nurses within the hospitals as well. So those skills really are beneficial. Thank you. Thanks.
Great. Thanks, Hayley. Go over to Jill, if that's okay.
Jill?
I just want to say I've worked as a carers lead within our mental health trusts for 15 years. And I was a bit confused about this role. I've done surgeries in carer surgeries in GP surgeries around Norfolk as well. And I have to say that most of the carers I've spoken to over the years, and that's many thousands, come with a whole host of problems. Many of them are not understanding about social care, about funding for care and things like that. And in my experiences, nurses don't have that skill set. And that's what concerns me about this being a registered nurse's role. I think I've done a fairly good job at it, and I'm not a registered nurse. And I've managed to support hundreds, thousands of carers over the years with advice. And although I can and do basic health checks, blood pressure and things and that type of things, but we do have the experts that you can then refer on to. So I'm still a bit unhappy about it being a registered nurse's role, because there are many people that have a good wide range of skills that could be really, really helpful to carers, and they don't necessarily have to have a nursing degree to do that.
Yeah, okay, Jill, I completely understand what you're saying, and I agree with you. The role you're fulfilling is different to the role that our carer support nurse was delivering. So she is focused, or it could be a he, is focused on health and well-being. So nurses have the skill to do the level of clinical assessment that is required in order to deliver its role. She has some knowledge of social care and the voluntary sector and can refer on, and her knowledge was growing as she worked through this pilot year, and she was able to connect people. She attended lots of multidisciplinary meetings, which were beneficial to her learning about resources that were out there, all this knowledge that you have developed so fantastically over many, many years. But the role she's delivering is different to the role that you're delivering. It's complementary, and it's about them working together. And this is the importance of that stakeholder work that I mentioned again at the beginning, to make sure that there isn't toe treading, and there wasn't toe treading that we picked up on. So it's important to have it clear that in your head that she's not providing generalised carer support, although there can be elements of that. The unique selling point, if you like, of this role is the attention to carer health and well-being that we know is such a problem for this population. We know there's such strong evidence that carers have unmet health and well-being needs, and their mortality rates are higher than the rest of the population, and we should be addressing that. And this is a mechanism to do that.
Thanks for that. I think
I can't convince you anymore. That's
yeah, it made it really clear that it's a complementary and it's around that super
Totally.
connector role, isn't it?
Yeah.
So is there any, there's quite a few more questions in the chat, but would anybody else like to come off mute and ask any questions while we have Morag with us? Lizzie.
Hello. I'm just wondering if maybe those of us who are confused around the clinical side of this role is because we're not clinical. And therefore we don't know what a clinical assessment is. I wonder if maybe explaining that might help.
Yeah, no, Lizzie, that's a really good point. And it's a real shame I haven't got Karen here to explain it, and because she's gone back to her district nursing role now. She wasn't available. So yeah, it's a bit like if we asked a nurse, and exactly as Jill said, if we asked a nurse to do a social care assessment, they wouldn't necessarily have the skills to do that. So it's just about recognising the skills that are required to do a comprehensive health needs assessment, to screen for depression and anxiety, as well as those sort of more basic things like blood pressure and smoking cessation. You know, you could give someone a checklist to check through. But those years of nursing training in observation, in recognising clinical problems, be able to prioritise what's important and what has to wait. You know, this is they're highly trained professionals in their clinical area, and it's coming at it from that clinical health angle that's so important, both for the carers' own health and well-being, but also their skills to care. So most of these carers are providing nursing care, yet we rarely make sure they've got the skills to do that. And so having a nurse to be able to upskill them in that was highly valued by the carers. And all I can tell you is that this was one of the principles for the role. The carers endorsed it, who received the role, and the stakeholders, who, particularly those who referred to it, referred because she was a nurse. They referred because she was addressing the health and well-being needs that they couldn't address.
Morag, I'm just really conscious of the time now. Yep. Harriet, I know you've got your hand up. Is this a different question, or is this still connected to the clinical aspect of the role?
It's really just to kind of highlight, we have a nurse too in carers in Bedfordshire, and the reason we chose a nurse and not like a you know, and band 5 or above is because it's about interpreting that clinical data, whereas anyone below a band 5 is not allowed to give more than signposting, and it's about interpretation of the data. So it was just to kind of put that on there after speaking to NHS really about who should be doing this kind of role and interpreting and giving the correct clinical advice.
Yeah, thank you, Harriet. That's great, because that endorses what Jen Kenwood said to me early on in terms of the banding that the role should be at. Thank you.
Thank you, Harriet. I think that is a really good place to end. And I think from what, you know, what I'm taking from this is complementary to both. It's not and or, it's very much how people, and it's that super connector knowledge broker role within both clinical and non-clinical. Morag, thank you so much for coming and sparing your time. It's a really interesting and such a valuable piece of work. We'll share the report and we'll see how it goes forward, and hope we will get to talk to you again. Just really conscious of the time, and we've got Andy who's come to give us an overview on no wrong doors for young carers. So more, I hope there's loads of questions in the chat box. If you do have time to stay with us and just answer some of those, I'd be really grateful. But of the interest of time, Andy, it's over to you.
Brilliant. Thanks very much, everyone. I'm conscious I have 4 minutes and I'm keen to make sure we don't run over, so I'm going to go straight in. So I'm Andy McGowan. I'm the Policy and Practice Manager at Carers Trust, and I'm really grateful for the opportunity just to come and give a very brief update and overview about no wrong doors for young carers. So just in terms of, excuse me for those who aren't familiar, so No Wrong Doors is a national template memorandum of understanding, and it's designed to improve that joint system working around how we identify and support young carers. It's been around now since 2009. The last version came out just after the Children and Families Act and the Care Act back in 2014, MOU in 2015. But what we've been asked to do is, on the back of the Health and Care Act, but also in terms of the first ever review that we've done of No Wrong Doors, how well is it working in practice? The MOU is being refreshed and it is being relaunched. Because what we found in that review is that in terms of only around about 7% of local authority areas across the country seem to have No Wrong Doors actually active and live at the moment. And the sort of common consensus is that it very much has fallen off the radar with COVID and the aftermath from that, as everything else going on as well. So the reason I wanted to bring to this group is because historically the MOU was just between children's social care and adult social care. But the feedback has very much been in terms of, given the sort of the duties in relation to the Health and Care Act in relation to ICBs and young carers, but also in relation, and you'll be glad to know I'm not going to talk through all of this on this slide here, but in terms of given the increasing evidence about the health impact on young carers, that actually it would make a lot of sense for actually at a local level, as well as children's and adult social care, ICBs also being signatories to that No Wrong Doors MOU. So you can see a whole load of information on this slide here, which will be shared around. But as you can see, currently we have over 15,000 children caring for over 50 hours a week. And if you're wondering why I've got a picture of Centre Court on there, it's not because that makes me feel warm, and that was summer, strawberries and cream, and we're now in winter. But just as a visual, if we gave a ticket to Centre Court for every child caring for over 50 hours a week, in that image there, we'd only have just over about 100 seats left in that 15,000 venue. Every single one of those would be taken up by a child who their head of household is saying they're caring for over 50 hours a week. And 3,000 of those children would be aged 5 to 9. And I think that's the shocking statistic that we're dealing with at the moment. And that's not the children saying that, that's the head of the household saying that as well. And in terms of, as you can see, in terms of some of the health impacts on mental health, would really flag up the APPG inquiry report. If you've not seen it previously, it came out last month, really highlights a whole range of impacts on education, on health, and on future life opportunities. But the other reason we want to really bring sort of ensure health are linked in is it's an opportunity to build on some of the progress that's been done through the Commitment to Carers programme over the last few years. Also, young carers have just recently been added to the Core 20+5 Health Inequalities programme, because it's been recognised about the differential health impact for young carers compared to other children and young people as well. But it can also help tackle some of the key systems-wide issues such as referral pathways, identification, recording of young carers, all of these challenges that often can really be really flagged up as well. And as I mentioned, it can support ICBs to ensure they're meeting their Health and Care Act duties. So under the Health and Care Act, ICBs have a duty to consult with young carers in the planning and delivery of services. Other partners, such as hospitals, also have legal duties on them as well. Obviously, this is an overview, hence why I'm whistle-stop going through from this perspective. I've put a couple of notes in there just as flags saying actually at a systems level, people will be able to have as many signatories as they'd like. So in terms of mental health trusts, primary care representation, drug and alcohol services, and we've seen in different parts of the country where that is happening. But what we didn't want to do at the national level is have to have all 10 of these signed up and around the table in order to get it signed off. We'd rather have those 3 core ones, and then local systems can add in terms of who they want, in terms of who they think is appropriate moving forward as well. So this is a really quick overview. I've got to 11 o'clock, so I'm going to finish there. Just say these are some questions for you to think about over the next few weeks, over your mince pies and Christmas films over Christmas. But how do we ensure we get it right? What are your thoughts and reflections? I've put my email address in the chat there. Please do get in touch. And as I said, I've got a date for the diary there. That is when the new MOU is being launched. We're also going to have supporting guidance, giving sort of practical examples about how you can tackle some of those issues as well. So this is a very whistle-stop overview. Thank you, Steve, for giving me a slot right at the end of the meeting to come in and talk about it. And of course, I'd be more than happy to do a fuller sort of conversation about it at a future meeting as well. But thanks very much for coming the opportunity to come and speak about it. And I'll stop there because I'm 1 minute over.
Thank you, Andy. That was amazing. I don't know how you did it. I don't know how you can talk so quickly. You are very welcome to come back to our next meeting where we'll allocate more time to you. So thank you for that. I have fundamentally failed to finishing at 11 o'clock. So without further ado, I'm going to wish you a very happy end to the day, a very, very festive break for yourselves, your loved ones. Hope you get a bit of relaxation and look forward to seeing you again in the new year. Thank you so much, everybody. Bye-bye for now.
Thank you. Bye.
Thank
Bye, Sean.
you. Bye.